IPC 있는데 이걸 하는 것 자체도 사실 기대를 안 했어요. 9시부터 컨퍼런스 있던데. 네. 괜찮아? 네. 뭐가 없다는데 괜찮아?
카메라.
이게 되는 거네. 소리 나는 거 보니까. Okay, let's go.
I think this ECG is almost PVC by Gemini. You can find the PVCs are running. The axis of the PVC, you can see in B1, ABB pattern. And in lead one is almost, it seems isoelectric, so maybe I think we can think about RGOT only.
And so
This ECG show sinus rhythm with ranges about 80 and regular rhythm, and I can see PPC. I think it's about 2 morphologies. I can see in V4 and V1 is LBBB and show its the origin, and V3 AVF is anterior axis, and so it indicates the anterior location and our transition steps from the V4 and so moving. So and then it is RBOT, anterior and basic.
RBOT anterior,
Yes.
septal side or free side?
And then it is. Yes.
Septal side.
Septal side.
Okay, and what else?
No question. Why the septal side? What make you septal side? This guy asking question. Anterior versus septal. What is the EKG characteristic of septal side?
AVF upward.
Hmm?
One AVF.
One AVL negative. Okay. And
What else? So how about the QRS duration? D1, D2.
Slightly, little bit narrower.
Narrower.
okay.
Right. That's a important feature because if it's a septal side, you can activate a right and left ventricle simultaneously. Therefore, interventional conduction time is going to be shorter. That which is sum of a QRS duration. Okay. So it's important to look at those features. What else you can tell us in this ECG? So we talked about this before. Electrophysiologist read the ECG different than cardiologist. We want to look at the mechanism of interactions as well. So if you look at the third QRS complex, PVC, the bottom lead 2 strip, what do you see just before the QRS complex? What is that? P wave. That's correct. But that bit, that P wave did not conduct, right? Because the QRS did not change. Sometimes you can have a partial fusion or you can have a capture bit phenomenon. But is it too early PVC came on before the conduction happens, so QRS didn't change. What does that mean to you? Do you think patient has a PVC, has a V ventricular atrial conduction, retroconduction or not? If there was retroconduction, what would happen? You would reset the subsequent P wave, right? So you measure PP interval, figure that out. But if you measure subsequent 2 sinus bit, PP is almost same as that PP interval. Therefore, your conclusion is most likely there's no VA conduction, right? This is important concept. Why is it so important? I'm asking you this question, that this is a little more step forward in our thinking. If you have a frequent PVC, the constant VA conduction, those patients higher instance of AV node reentry tachycardia. because of a retrograde infiltration impulse will dissociate fast slow pathway. Therefore, condition nodal conduction, more pronounced dual AV nodal conduction, which causes tend to have a re-entry mechanism. Okay, so that's a fascicular VT, for example. We discussed yesterday. Dr. Jason Nam presented what? HV timing, negative, slightly positive, so on. And that's why fascicular VT, up to 18% patient will have AVNRT. So this is something that we're going to start moving forward with you guys. Okay, it's not simply just reading ECG anymore. We got to discuss with you, start thinking this forward. Okay. Anything else you want to tell us? You said something about the different PVC there, the last big complex. What do you see? My question is why is last complex different? What are the possibilities? We have to talk about that.
Huang? Junior Huang?
Oh, yes. They think you're my son now.
Whenever I ask the call the Dr. Wang, I was surprised. We have two Wangs.
What is it? So I think we have talked about possibilities, right? What are the possibilities that, PVC changing? Again, the answer lies into the PP interval. If you look at that in V4, V5, look at the S segment. There's another hump in there. Yeah, right there, guy. Just before that, just before. Yeah, that guy. Look at the B4 also. Different than other PVC, slightly different. So may raise a question: is this P wave fall into that period of time, has a partial conduction resulting fusion bit? Is a possibility one, right? Or coupling of PVC is too close, they're causing what? Different exit, aberrancy type of behavior. In other words, if you have a PVC focus that fire repeatedly, first PVC conduct the peripheral conduction, second may not able to conduct the same peripheral conduction, then exit different site. That gives a slightly different morphology as well. It's a matter of a refractory tissue conduction issue. So those things you need to think about it. Okay. So obviously meaning is different. Now, look carefully. What is the end of that second complex P? That's a P wave downstroke. Can you point the arrow?
This one?
I think this is the arrow.
Which one?
I'm just this guy here.
Yeah, yeah.
That guy. End of a T. You do one.
I don't think that is P wave.
That's a P wave?
No.
No, it's not. Okay. So that's a possibility you have to discuss as well, right? But if you measure the PP interval, what did you measure with a finger? How does it look? Fall into that QRS complex that we did not see it? In other words, this PP interval, you measure here, fall into the what? Inside the QRS almost, right? You measure. Therefore, it's possible this is a fusion. Because the conduction of, since there's no VA conduction, and there's,
I would like to argue.
Okay.
If it is fusion bit,
uh-huh,
at place the conduction system related to narrow curves should be overlap, but if we consider the refractory period of previous PVC, it is too short.
What do you mean too short?
Hmm.
Why do you think it's too short?
Too short to be conducted through the normal conduction system.
No, there's a too bit of a PVC.
I know.
I agree with that.
I know.
Question is the morphologic change is due to the partial fusion of AV nodal conduction, or this is just a matter of another exit PVC. That's what we discussed.
We discussed that this patient doesn't have literal P.
Right.
And
P.
we need to
Measure the
measure there. And
fall into the QRS complex.
It should be narrow curve should be the. Can you change your arrow here? So that
Yeah, PP measure is it fall into this QRS.
it should be falling here.
Right.
And this point is the refractory period of previous PVC.
No. Refractory period PVC,
Uh-huh.
but if a sinus rhythm comes here,
Uh-huh.
you got a long AV nodal conduction. Your AV nodal conduction is going to be longer because complex block You don't know where the complex is, block is. Is it infrahesion or suprahesion or nodal conduction block?
But if you, can you measure the narrow course outline interval? Use caliper.
Caliber. You're talking this one to this.
Yes.
Okay, measure that. Isn't that the same as this? Oh. So you measure this to double PP to this PP. This guy to this guy. Let me see. Yeah. Okay.
Long.
You're pretty close. Okay. Drag over there. That's what you got.
No. 도와줘야 돼.
Go to the other way of form.
So I would like to bet the last wide course speed is just the previous coupling with different axis.
Is it possible? That's what we're discussing it.
Okay.
That to the next one. No, you got so long. You got to cover whole thing. Measure whole thing. Long. Yeah. Keep coming. Yes. There you go. How about measure RR interval?
No, last one.
Last.
Yes.
What is it?
See?
No, it's fell into the same coupling.
Yes.
Right. So if you look at the PP interval, this is sinus bit. Yeah, I agree with you. But the question is what happened here? That is an issue because you got another piece hidden here somewhere. So question is that do you have some nodal input coming down to the partial refractory, whatever conduction system can cause this, yes or no? That you never would approve it. But
it is too short to be conducted.
I don't think it's too short. It's long enough. If your PV will fall here inside the QRS,
yeah,
it's a long PR. So that a possibility we cannot exclude it. So that's a two distinctive possibility here that you need to think about. Okay, maybe that's one of the reason QRS got a little bit narrowish looking. This guy here, a little bit narrower than that. So
intrinsic deflection time is slow.
well, it depends where you start the QRS complex. This is versus this, right? Very sharp upstroke. So I don't know why it becomes a summation of amplitude tall PR wave here. That is something that you need to. Anyway, that's the two different possible you need to discuss. Okay.
And I would like to ask Dr. Cho. So when you look at the B1 to 3 previous course morphology, are you sure it is RGR4 track anteroceptal area based on the course morphology? You sure?
Answer lies here.
Okay.
Okay. Answer lies here.
Why?
I think in B1 is negative chorus complex. It comes from right side. But,
Yes.
B1 is also negative. It maybe comes from right side. It's two different.
No,
sides.
B1 is, if you look really carefully, is naturally all negative. There's a small R, and then go down. And then you can see activation very sluggish first.
Yeah.
Okay. If you're the right side septum, it's going to be very sharp drop. That's another thing. Second thing is AVL is a QS completely. Okay. And then you lead one dominantly S wave. So this is most likely septal focus. You cannot exclude the possibility of left side. Therefore, in practical sense, what? Before you ablate, you're gonna map both sides. That is the answer we're trying to get to. Okay. So EKG tell you a lot of things about how you think you address this issue. I'm sure you're thinking about ablating this thing. So that's why you presenting to us today. But it's not just ablation. What we need to do, brain exercise enough to open the possibilities. And the discussion difference is a good thing in EKG, okay? Make everybody think better and then widen the spectrum of a view of what you see.
when you look at the V2, so there's an R wave with a relatively long intercoil deflection time.
Right.
If you see this kind of QRS morphology, this ECG smells fish.
Which is a
You need to,
yeah.
it
Right.
may be not the typical alveolar flow.
So what happened? Tell us a story now.
And another is the 6 months later.
Oh.
Okay. Now what? Yes, but doesn't bother
Not
me.
too different.
Yeah.
Yeah. Why bother? Is it bothers you?
Different.
Or different.
It's not
Or
all
different.
different. It's just the other side of the story. Yes. So this one, what we saw before, right?
Yeah.
And then you got coupling closer, this one. But make sure that there's no P wave conduction here before you interpret that it's associated there. Okay. So now, this is one is the left bundle, one is the right bundle, right? That's what you're trying to refer.
Another thing I would like to point out from the previous ECG and this ECG, why sinus PP interval is short? His heart rate is around 90 or over 80. So there's
Or repeat
something-
interval too short.
I mean, the heart rate is baseline heart rate is pretty fast.
Right, but then the patient has a significant rate variation. From this PP interval here, looks like slightly faster than this here, right? But patient had a bigeminal PVC, and then you got a almost coupling longer pause and then slow down. So based on that, what you think this is an older guy, young guy, age-wise? This EKG of a young person or older person?
We can ask to AI.
No, don't ask AI. So younger people tend to have more sinus arrhythmia than older people. So this tended to be probably younger person rather than older guy. That's what I would do favorable. Now, what's the interpretation ECG? Huh? What's the AI says? Never mind. Okay. Now, why the EKG morphology changes so much? Now you got a wider QRS with a notching, a lot of notching going on, even right bundle, I mean like left bundle pattern, right? You see it? So question is, this notching is a P wave hanging in top, or is there something truly notching? What do you think? You have to measure the PP interval again, right? To make sure that's not the case. But what is the market feature change here? What is it? What are noticeably concerned? Let me ask you this question now. Your QRS closer to the T wave now compared to the previous PVC is almost R on T becoming. And then QT interval, other things looks pretty much the same. And then just two different morphology PVC with a complete opposite direction. So that raises a possibility what? If you had a one focus in a septum, one possibility that the existing both sides. That's one possibility. The other one is because the B1 still have a Q wave in even right bundle. Let's see this. Let's see here.
I think they're most similar QRS morphology comparing to the previous frequent PVC ECG. Looks like the right precordial lead is
Yes.
PVC, and their lead 2 became taller, and the intrinsic coil deflection time of V2 is longer.
Right.
So I guess this PVC coming from the left side cusp area or the LV summit area. And if you look at the wide QRS rhythm and the limb lead side, left side, the 2-3 AVF became the shorter, and the lead one shows a small Q wave and DVS wave. So probably this exit is much lower than the previous PVC one. So I guess it could be coming from the same focus to different exit.
Lower exit.
Yeah.
Yeah. Left side.
And my curiosity is the third PVC. the B1 to 3 second PVC.
Mm.
Is RBB morphology relatively sharp and the short intrinsic deflection time and fractionation in B2 and the B3 and the lead 2 shows a negative wave. So it could be the left side posterior septum. It is a little far away from the other two PVCs. So
It's gonna be
yeah,
yeah, because of when you involve septum, your septal fascicle cannot be manifested to express it because your preferential conduction gonna be mostly posterior fascicle. That's the thickest fascicle you have. Since with the networking, diagnosing septal PVC left side is the most hardest thing to do in ECG. Okay, because always going to have whichever Purkinje conduct faster gonna exit through that. So this is the challenging. So there's always valuable to think that this is maybe single disease causing this would be one focus in the septum exiting bidirectional. Okay, that's one possibility. The other one is that one focus with the long exit left side septum through the Purkinje fiber because it conducts very fast, which is it looks like that way because it almost looks like posterior septal fascicle PVC here, but it may not be because it's very narrow complex, almost vascular PVC.
Yeah, I think this guy and this guy is the same one.
I think it is.
Yeah, but I think so. This T wave morphology is slightly different from this guy.
yeah,
yes.
And so yeah,
there might be P wave at the top of this thing. Yeah.
yeah. So this and this and this are, I think,
Mhm.
these guys, those guys are
Right.
PVC, but
I don't see your laser point.
yeah,
Please. Better
Bottom,
than
bottom.
that.
yeah. This
Okay,
guy,
good.
this guy, and this guy will
Can you
be,
follow the mouse?
yeah, this and this and this guy are gonna be PVC, but I think this could be the aberrant conduction from the premature HR complex.
Formation there.
Yeah.
Now the if you look at the
RBB aberrant.
yeah, this QRS complex to this R, this to this R, this is longer. RR, if you measure, I think is longer. That's why maybe when you have a coupling longer, you have a more. First PVC was in previous ECG looks like. I get closer, maybe looks this. So question is that this would be different preferred conduction through the right side septum that we cannot tell, okay? Even though there's a P wave notching here. So there's, I think, interesting physiology, but question is that why this patient having so much different PVC, different morphologies. Obviously, the more different variation morphology PVC, they always will learn that the poor prognosis compared to single monomorphic PVCs.
And also if you look at the narrow QRS rhythm conducted from P wave, it shows a left anterior hemiblock. So I think that this patient has definitely some conduction problem. And I never seen such kind V2 sharp fractionated potential preceded by wide QRS rhythm. That could be the conduction system and fascicular
Yeah, I think it is.
related.
So this patient has a septal origin.
And the baseline heart rate is pretty fast, consistently fast, and multiple morphology QRS and conduction system disease. So probably this patient heart is not healthy.
Okay. Even the sinus rhythm
how's that?
QRS.
Normal? Normal echo. Okay.
Yeah, GFS reduces.
Hmm?
Mid-range GFS reduces.
Reduce, yes.
Well,
First it was 48, now it's 47.
47. So what will you suspect? What is differential diagnosis based on the ECG?
how old the patient? First thing. Huh?
You are
60, okay. And then the patient has hypertension, diabetes, okay.
So which disease involves from the conduction system, make heart failure, and eventually the BT and heart failure? What kind of disease you include in your differential diagnosis? Mid-range heart failure.
Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range heart failure. Mid-range he
you should suspect some infiltrate disease, inflammatory cardiomyopathy, including sarcoidosis.
You could even be a diabetes cardiomyopathy. So,
Yeah.
yeah, you don't know that. So issue that the diastolic heart failure is abnormal also. So patient with both systolic diastolic dysfunction and the cardiomyopathy looks like.
So forget about the very inclusive diagnosis, dilated cardiomyopathy. In the generation, you should try to find out the cause of mid-range heart failure. Okay, because prognosis is apparently different, and also the management is also different. If it is really infiltrative disease related cardiomyopathy and associated with non-sustained VT, you should consider the IC implantation, even though you need more evidence.
Now so what did you do? Did you do anything to the patient? Or you mapped the patient? Mhm. So you did
Probably the operator suspect is a PVC-induced cardiomyopathy.
until septum LCC. So it's between two, yeah.
So single point ablation eliminate all three PVC?
No single point ablation. You
Well,
ablate the both sides, looks like.
No, I mean that there is another PVC from the posterior septum. We discussed from the with
The ablation in this site from right and left, outflow, eliminate all. No more PVC? Okay, that's what he's asking. So there is a possibility that the ejection fraction is low because the patient has a high frequency burden PVC. And it just remains to be seen during the follow whether ejection fraction recovers. Okay, so that means that that about the pattern PVC is basically involving some near conduction system activating his Purkinje quick. That's what it looks like that one. Yeah, it is not that uncommon. High septal PVCs can manifest both side exit, and then they tended to be very narrow. So that's why I said the fascicular pattern PVC. So would it be equivalent to the upper, reversal or upper, form of a fascicular VT? Looks like that way, unfortunately, but it is not very common, fortunately. Yeah.
I think that the ablating this frequent PVC is good choice, and you can follow up echo if it's normalized, it's good prognosis. But at least before bring your patient to the EP lab, you need to explain there's another possibility, and that this could be some progressive heart failure disease. Then, even after successful ablation, heart failure aggravated, and you need ICD pacemaker. If you explain it before your procedure, patient and the family doesn't complain.
Now the one thing is that where did you ablate LCC or not intercuspid? And this is not the earliest spot. This is the left. This is the right and left coronary cuspid. Looks like this is left main there. This is the way you ablated. Where did you ablate? Do you know? This looks to me intercuspid space activation here. Okay, you go already into the cusp here, then between two. And the right is also looks like a little bit early, and the left is early. So I wonder whether you could did you map the intercuspid space or not in this case. Something you need to think about it. Okay. So when you look at the next time this type of 3D map, this fairly distance away, that is complete two different structure, they almost equal timing. You got to make sure that the desert below is not earlier, maybe spreading this way. Okay. So always 3D mapping, when you finish, important, look at it. Does it make sense to you? And then also raise a question about other possibility of interpreting this better. If you had the third point is even earlier below here, how to explain that? So it's a keen observation and then careful evaluation important. Third thing, I think your answer going to lie on mapping EGM from here and here. You click at the point, take a look at the EGM. How the EGM looks. If this right cuspid EGM looks far fielder than this, then even more into the intercuspid beat below. Okay, So it is something that we have to move forward for you guys, a lot of part of your training, how to interpret EGM, how to try to make things in relation to the anatomy. That's important. That make you better, EP guys and better thinking. Okay? Yeah. So from now on, next time, when you guys are doing 3D mapping, bring the EGM. Okay? Because that needs to be trained as well. Because the 3D mapping, EGM, filter setting, recording setting are completely different than what we see in PRUCA. So you need to get familiar with both of them. Okay? Even though you're not going to use the 3D that much, but I think it's important.
Actually, she wants to use the same case at the EGM conference and ECG
Huh?
conference.
Okay, go ahead. Sorry. Go ahead. Let's do it. That all, okay? Then?
Just all finished.
That all?
Yeah,
What
EKG.
do you mean it's conference?
ECG conference. Okay, next week, ECG conference.
Next time he's not here. So you can do whatever you want to do.
Wow, you pick up the very interesting ECG. Great. Enjoyed it very much. Who? Dr. Yu. Oh,
I tried to provoke the third morphology PVC during the procedure,
Mm.
I mean the RBBB pattern, but it never.
Yeah, I think it's a trigger activity of a conduction system. But is it possible that subtle mid-myocardial location just to have a more dominant exit to the right and then one sort of the left side?
so anybody can explain how this kind of fractionate potential, like bipolar electron shown in the B2, what is mechanism?
Why not?
Zigzag conduction?
Why? Why not?
Hmm?
No, this is typically sometimes you can see from deep epicardial tissue exiting the conduction system early. Look at the B1 very beginning. There's a small high frequency signal there, local guy. And you go down quick. So there's an initial delay there. Can you imagine that? Yeah, no, just before. That small guy, yes.
Looks like the bipolar electron.
But in the right bundle is all atypical because the initial cue. You see?
After looking that interesting surface ECG signal, I assume this patient has some pathology.
Well, it is likely, but now if he's a pathology going to be still mild, ejection fraction recover, it's going to be more important for you to educate a patient for the preventive measures now, rather than trying to do something. So you need to make sure guy control diabetes, exercise, all that good stuff. That's our job, not to bring the patient to the lab, to prevent them not to bring the lab. That's our job. Okay, even though we love to blame, that's not the way it is.
Okay, thank you very much.
All right,
Okay.
very good. There's no case of present EGM there.
No.
ECG only,
It was supposed to be
9 o'clock.
Dr. Om's
Lecture, oh, there's a lecture. I'm
but,
sorry.
It disappeared.
It disappeared?
To the
Oh.
CCU.
Oh, he's taking call. Oh, he's on call.
It's a duty.
Oh, he's on call.
CCDT.
He's on call. Yeah.
So please, during the IPC program from 9 o'clock, actively discuss and question, ask a question.
Actively discuss, not question.
Question. Okay,
Well, I'm the first guinea pig this morning, so you guys ask any question you want.
each fellow have responsibility to ask at least one question. Okay. 오케이. 9시에 그러면 시작하는 거죠?
I think so.
그러니까 1시간 또 펑 비워버립니다. 자, 제가 어떻게 여기 계시겠어요? 제 방에
Oh, I'm gonna do case conference with them.
케이스 컨퍼런스 하실 거예요?
No, you can go. I'm gonna with this guys. I got a very interesting case.
준비를 안 했을 텐데.
I have a slides.
오케이, go ahead.
case from here, but I sold that. But we do AVNRT. Okay,
You can do that.
I need to do, now to discuss this because I got a system anyway. Oh, okay.